Ready? Hello, everybody. I'm Mark Williams. I'm a general surgeon up at Mulberry campus for Muscatine, for UnityPoint. I have a doctor saga to follow, which is going to be kind of interesting because mine is more of a technical process. His is more of just kind of a general. I think he did a great job and had a great presentation, so hopefully I can fill his shoes here. But a little bit of background about me. I grew up in North Carolina. I moved up here with my wife in Princeton, Illinois. I've been up there in practice for about 16 years or so, 17 years total. And my background is I did my PhD training at Bowman Gray in cardiothoracic surgery research and had interest in cardiac surgery, and things changed, and I like the variety of general surgery, so I kind of followed along that track. But I did my training at University of North Carolina, then back to Medical University of South Carolina for my surgical training, and then we moved up here afterwards. I had interest in this, in venous reflux, so we're talking about chronic venous disease today. There's some issues I want to discuss to kind of educate people on how, and issues that are very common in the disease process, and a lot of people have it nowadays, and how we can manage it and treat it. So chronic venous insufficiency is a disease condition of the valves of the veins. It leads to poor venous return of the blood back to the heart and causes pooling that tends to occur, and that long-term causes damage such as venous hypertension, which ends up causing the lipodermal sclerosis, which is basically this hyperpigmentation you see. You see the scarring and bronzing the skin, this kind of gator distribution of the skin that you see in patients. You get fibrosis and chronic swelling ulcerations. And so the goal is to try and prevent the long-term consequences associated with the disease and help medically manage it. It's also known as venous reflux disease and venous hypertension. So just a background, it's very prevalent. There's 30 million people in the United States that have it. Of that, surprisingly, only about 2 million people seek treatment for it, and there's about 450,000 actually get treated for it. So it's very common. People just kind of ignore it because the disease process is usually pretty mild for the most part, but some people have severe problems. I'm going to be showing you some pictures today, unfortunately, of some of the more severe stuff, if it's okay. I've got unfortunately got some ulcers and some wounds that are a problem that are typically of this. So if you have any questions or concerns, or just let me know. So surprisingly, venous reflux disease is much more prevalent than heart disease and peripheral vascular disease. We're finding out that, again, this is a very mild disease most of the time, and people just kind of ignore it, and they feel like, well, I'm just getting older, and I'm having problems, and it doesn't bother me that much, so I have to kind of live with it, but you don't. So risk factors for the disease: if you're over 40, if you've had multiple pregnancies, if you stand for long periods of time, and actually, surprisingly, sitting for long periods of time are actually worse. So sitting at a desk job but not getting up and moving around is actually worse than standing. But a lot of patients we see are patients that have been standing on their feet long term for their entire life lifting. Other things: smoking damages the vessels. Heavy lifting causes more pooling in the vessels as well. And then, of course, obesity, that actually impairs the flow of blood back to the heart. So that kind of adds to this. So to understand this whole disease process, I need to kind of go through a little bit of the anatomy and discuss that first. But let's get to the numbers. So some of the worst conditions you see from venous reflux are ulcerations, breakdown in the skin, whether you've got a chronic wound. And they estimate 1 million people have venous ulcers a year. So it's pretty prevalent. A lot of people have it. Of those ulcers that you see, most ulcers on the lower leg are related to the veins and not the arteries. And long-term, varicose veins are not just a symptom, are not just cosmetic, but they show the underlying disease process we're going to talk about today. So kind of need to back up and kind of talk about the difference between arteries and veins. So arteries bring the blood to the feet, and veins bring the blood back to the heart. So symptoms that you would typically have from arterial disease is that you have pain with walking. It tends to occur in the foot or calf. It tends to require that you have to stop and rest. You can develop a cold foot from the lack of arterial blood supply to the foot. It may be blue. You might notice that you have to dangle your legs off the side of the bed at night. It wakes you up from sleep, and you have to dangle your legs or get up and walk because the blood supply is not good enough. So you have to walk around so that gravity assists you with getting some of the blood down to your feet. You notice that you get a hair loss on the legs. You're starting to lose the hair on your feet and legs. So you don't have to shave, but that's not a good thing. And then the worst of it is when you develop loss of tissue, such as ulcers on the skin, which tend to be in arterial disease, tend to be on the foot and the toes, more or less. So venous symptoms, this is what we're really focusing on today. You get the achiness, the heaviness, the itching, the burning, swelling. Swelling can be multifactorial. It tends to occur from many different reasons, medicines, your heart problems, kidney problems, but it can be a sign of venous insufficiency is what we're talking about. The other thing is kind of cramping and surprisingly restless legs. People that develop restless legs, this might be a source of it. Other things that can happen is you can have varicose veins. The varicose veins are basically a superficial sign of the disease process that's below, that's occurring deeper in the veins in the leg. Again, with the hyperpigmentation, like we talked about, where you get in a darkened area of the skin, kind of that bronzing, that's actually a tattooing that occurs. And then also dependent rubra, your feet turn purple. That's because the blood that's pooling down in your legs is venous, and it's kind of bluish, so your legs kind of turn purple. But when you elevate your legs, they're back to normal. Your feet are still warm, but it could be a sign of either arterial or venous, but you kind of have to look at it and see. And then again, the ulcers on these are actually up on the calves and the ankles. So from the ankle to the knee are where you typically see this type of ulceration. So you see people who have breakdown of their legs start to weep. They may not actually have a true ulcer, but the skin gets so tight and so shiny from swelling that the leg starts to weep fluid. That's where you're starting to see signs that the swelling and the ulceration and the venustasis is so bad that the tissue's starting to break down. The pain is actually when you've been on your feet for long periods of time. So you've been standing for long periods of time, you come home and you go and you feel like the pain, you just got this achiness, this heaviness, and it's relieved when you actually raise your legs. So kind of go back to the anatomy. So the red in here in red is the arteries. Arteries bring the blood down from your heart down into your legs. And then veins in the blue bring the blood back to the heart. So within the veins, there are these little one-way valves. And that's what's the most important thing in this whole process about the venous insufficiency, is that those one-way valves are the primary culprit where they stop working properly. So in the veins, there are two systems. One's the deep system and one's the superficial system. So the arteries bring the blood to your feet. The veins bring the blood back to your heart. The veins themselves, there's a deep system where the blood flows continuously back to the heart, and it doesn't pool. But the superficial system is something you really don't see, but the blood just kind of works like a little lock system. So these little one-way valves allow the blood to flow back towards the heart, and in the process, they pool. So they work by calf muscle pump, which is basically you walking around, you moving around, your legs squeeze, and they push the blood towards the heart and towards the heart with these one-way valves. And I'll show that here in a second. So the deep system is when you've ever heard of deep vein clot or a DVT. That's where the blood clot occurs in the deep system, and that you can't have. That causes problems. And it also is dangerous because that clot can move to the heart. Whereas in the superficial system, you have all these collaterals. So if you close part of it off, These collaterals allow the flow to go around, hopefully in a manner in which the vessels, in which the body has vessels that are actually working properly. So as long as gravity is working against you, unfortunately, this process is continuous. And so we can close these diseased vessels and divert the flow of blood around them, and that hopefully will reduce the amount of problems that you're having with your legs. Again, the clots tend to not be dangerous. They unfortunately may be uncomfortable. You may develop a little clot superficially, but it doesn't usually cause any severe problems or anything like that. And again, gravity, because we're upright, increases the pooling. So going back, so trying to explain how the vessel works. So you have these little one-way valves in the blood vessels, and pretty much all veins, not arteries, but just veins. And they're directed towards the heart. So the blood always flows towards the heart. And what happens is, initially, the blood in the deep system just keeps on flowing. But in the superficial system, the blood flows up and stops, and up and stops, and up and stops. And what happens is when it pools, then if the valves work properly, it just holds the blood. But if it doesn't work properly, then the blood goes down and backwards, and that's what venous insufficiency is, or venous reflux disease is, or venous hypertension, because that pressure that's transmitted from here goes all the way down. So it's not very high pressure here, but when it gets close to the ankle, it causes the problems. And that's the reason you see pretty much a lot of the disease and a lot of the consequences and problems with it being around the ankle and just above up on the lower leg. So what I was talking about earlier was this calf muscle pump. So basically, you've got these little one-way valves, you've got the muscles around them, and when the muscle squeezes, so you just shift your weight, the muscles push against the veins, and the blood flows towards the heart. But then it goes up and stops. So if you're not moving around, if you're stagnant or you're sitting down, then that blood is going to pool. And the pooling is what causes the problems with all this, is that pooling eventually causes these little vessels not to work the way they're supposed to. So again, it's kind of like a lock system. So you're trying to go upstream. So it has to go to here, and then you get some pressure. You have to raise that pressure up, and then you push it forward and forward. So this is my analogy. It's like a lock system, and when you're talking about like a canal. So within the deep system, or the superficial system, we've got this long vessel that runs from the thigh all the way down to the ankle. This is the vessel that we're mainly talking about. It has these little one-way valves that go up and down. The deeper system has the one-way valves as well. But what happens is there's little rungs on the ladder that cross all the way up and down. And so you can have problems with either the valves inside the vessels over here, or you can have them where they connect the two. So that is an issue that some people run into, where you don't see this vessel causing the problem, but you see these little connections. So this is a busy slide, but basically what I wanted to show was that you had this really long vessel going down. You've got all these collateral flows, so if you cut it off here, you can show other areas. This is the vessel that we deal with most of the time. So again, most of this is caused by the venous pooling that occurs. The venous pooling occurs because you're sedentary, you're sitting around, not doing much. That allows the blood to pool for periods of time, and over a long period of time of chronically doing that, the valve stops working. It starts to stretch out and spread out, and then it refluxes backwards, and that causes the problem. Obesity, so that actually contributes because it impairs the flow of blood back to your heart. It also impairs the lymphatics. The lymphatics are the tissue that bring fluid back to the heart, not just blood, but fluid. The arteries bring blood to the tissue, but then you end up having fluid that's leaked out into the tissue, and that fluid has to be pulled back somehow outside the vein. And the lymphatics do that, but the lymphatics have a lot less pressure than even the veins do. And when you impair that by being pregnant, you impair that by having blood clots in your legs, you impair that by being overweight, all that tends to impair the return, venous return and lymphatic return. Multiple pregnancies, again, what we talked about, it just kind of causes pressure on that area and keeps things from coming back. Again, standing and sitting for long periods of time, because you're not, like I said, standing allows you to kind of move, and you end up having the muscles in the calves kind of push that along. But if you're standing for long periods of time, gravity is the highest. So gravity is pushing pressure on that area, and over a period of time, it just stretches out the vein, and then the valves stop working, and then you get the reflux. Smoking damages the vessels. It's not just the arteries, but it damages the veins as well. Family history of the disease, basically patients that have problems, it's very common to see it in other members of the family. And the reason being is they tend to be a connective tissue. Some people's connective tissue may not be as strong as other people's. It may break down easier. So those are issues associated with as well. Heavy lifting, because anything you put pressure on is going to put pressure down there as well. And then as you age, that obviously occurs. So again, like we talked about, these little one-way valves, the vein that allows don't have an animation for this, but basically the blood flows up, and then when it pools, it just stops there, and then it keeps on moving up. But when it's diseased, the blood flows backwards. So the venous reflux that we're talking about is where the blood flows backwards, and that becomes chronic and progressive. Once these valves are separated, then it's really hard to get that to actually be fixed. So what we can do is we can help with symptoms with that, but the overall goal is to treat that underlying disease process to help reduce the chronic long-term damage that tends to occur from the process. So what happens is you get the vein, and then the vein starts to stretch out. These one-way valves kind of go back and forth, and then you start to see the varicose veins. That's what you're seeing here, is that over a period of time, that pressure causes the vessel to be tortuous and twist and turn, and that's the varicosity. And then sometimes they'll even become aneurysmal to a point where they're kind of ballooned out. So I think of this as a tree when I talk to patients. So I think of the tree as a trunk where the greater saphenous vein is the larger vessel in the system, and then you get varicose veins, which are smaller, and I'll show you pictures here in a second, but reticular veins are even smaller than that, and then the telangiectasia. So I think of them as the telangiectasia being the leaves and small branches, but you want just kind of the tree in reverse. So what you want to do is you want to take care of the trunk first, and then you work your way down. So you take care of the trunk, then you take care of the limbs, you take care of the smaller stuff. So that's how I kind of tell patients about this process. So again, we've got varicose veins here. This is where the vein comes off really high in the leg and then kind of comes all the way down. I don't know if anybody has seen this before, but there are some people that have a situation like this. The other is the reticular veins. So these are the little small blue veins that you see. You can see them anywhere on the body, but they tend to coalesce around the ankle. And you see this disease pattern where these little tiny veins are here. And that's because those little veins have little valves in them, and they've done the same thing, but they're just not as big as these things. And then the telangiectasia is the same thing, but they're spider veins. And these are more cosmetic, and this is kind of two for the most part, but this is kind of the same process going on at a smaller level. So when we start talking about this, and this is where I'm going to show you some pictures of kind of how bad it can get. This is how we kind of classify the disease, but what we're looking at, you've got telangiectasias and reticular veins, then you get these large varicose veins, and then you get swelling. You can see this leg is larger than the other. Swelling, again, is multifactorial. It can be due to many different things, but when you kind of have one side swollen over the other, it tends to mean that there's something going on with the blood supply, or either the venous supply or lymphatics to that leg, or there's something going on that's different than the other side. When you see both legs being swollen, you're talking about maybe cardiac issues where you have to have a diuretic to kind of to take care of the swelling from that. But that's when you start to looking at, but again, swelling, kind of unilateral swelling, kind of is, hey, something's going on that leg versus the other side. Now, here's where we talk about. So you get pigmentation. You start getting hyperpigmentation where you get redness. Then sometimes this will break open and weep. And then you get the chronic tattooing. And that tattooing is what's happening is the the skin and the capillary beds, the very, very small blood vessels in the skin are being damaged. When they get damaged, they actually cause a leak of blood into the tissue, and that blood gets reabsorbed, but unfortunately the pigment, the heme pigment from the blood, actually tattoos the leg. So that's what you're seeing. This is a tattoo of the blood. And somebody didn't have to inject it, it's actually coming from your own body. And that's what you can see there. Now, other things you see, there's ulcers that people can have. So this is the dependent rubra, where your legs kind of turn purple. There's a lot of reticular veins here, but the legs kind of turn purple. It didn't really show up very well here. This, again, is that hyperpigmentation, and this is one of the bad ulcers. And it can be as bad as it goes up the leg, not just around the ankle. I mean, in chronic wounds, we tend to see patients that have worse stuff than this. So when we talk about the ulcers, briefly, if the ulcers are on the foot, then you worry about arterial. If it's in the veins, they're usually up on the leg. I'll just kind of go back through that. So again, these are long-term effects that occur from the disease. You've got their multifactorial swelling, again, like we talked about. It could be due to medicines, it could be cardiac, renal, but it can be a symptom of this disease process, and and this is where we can kind of say, hey, are you having the achiness, the heaviness, the itching, the burning, swelling on top of on top of everything? Is that potentially from venous reflux disease, or is it related to something else? Again, the hyperpigmentation we talked about, that's that tattooing. The dermatosclerosis is just the chronic scarring. You get a woody appearance to the leg. The tissue is really firm and solid, and you get changes. That's where it gets so bad that those changes are kind of irreversible, which can lead to a chronically swollen leg, chronic wounds, and stuff like that. And this is kind of an example, again, the hyperpigmentation, and this has been contracted. The legs aren't really that short, but the picture was larger, so they were a little longer. But this is kind of this is the type of patients you see that has the chronic long-standing disease and is lucky not to have ulcers that much. There may be some healed stuff here, but they've got the large varicosities. Now, once it gets to the point where there's irreversible changes, then you get this chronic swelling and damage to the skin to the point you get what's called lymphedema, where the tissue no longer can bring fluid back to the heart, and the leg is chronically swollen, the tissue is chronically damaged, and that's what we're trying to avoid. We're trying to avoid that. We're trying to avoid the ulcerations, but we're also trying to help people feel better overall from the disease. So the way we start with this, we evaluate you, do a physical exam. We're looking to see kind of general medical information to see things about what's going on with this process. Then we look at an ultrasound to determine where the reflux is occurring, at what levels. And then we also make sure that you don't have a clot in your leg, in the deep system. And this helps us determine where we're going to treat that area. Insurance covers most of the workup and treatment for this disease process. It's not cosmetic. Varicose veins are not cosmetic. We treat the underlying process. Now, medical management, when we talk about pooling, so if the veins are pooling, what do we want to do? We want to prevent them from pooling. So we want to be active. We want to exercise. We want to get moving around. We want to, if we have to stand for our jobs, we wear compression stockings. I wear them myself. That helps to provide pressure to reduce the swelling, so the swelling doesn't tear the skin down, because it's the combination of the pooling and the swelling that damages the tissue and skin long term. Then elevate your legs at rest. So when you get home, you elevate your legs. You try and put them above your heart, but unfortunately, that's just to help with symptoms. It helps to get rid of some of the swelling, but all these are just medical things that help you feel better, but they don't treat the underlying disease process itself. Again, medical compression stockings, as you've seen them, I'll go back in a second, but some people will have them. They're kind of toe to knee. Some of them have all the way up to their thighs. If they have bad swelling and disease, they even go up to your thighs. Sometimes you can get ones that zip up as well, but those are the kind of the mainstay of treatment is the compression stockings. And I put patients in compression stockings if they have swelling of any type, that's where you can push on the skin and it kind of pits in. That helps to reduce the damage that may occur to the legs. Go back. There we go. So that Uniboot is what we were just showing that shows down here. An Uniboot is a special type of compression wrap that we use for ulcers. So if a patient has an ulcer, unfortunately, the ulcer won't heal because of the pressure on the leg. So unfortunately, we have to wrap them with compression, but we also have to change a dressing on the leg. So they end up with almost a cast-like material wrapped around their leg. They have to wear this continuously. It's usually multiple layered, so it's almost like a cast. And it has to be changed 2 or 3 times a week because you've got a wound underneath there that has to heal. And that wound will not heal without some form of compression to help reduce the swelling and all that's going on. And unfortunately, you tend to have to wear them for weeks to months to get them to heal. So we don't want to get to that point. That's what we're trying to avoid. And then if you need something for pain, we just use ibuprofen or Tylenol as kind of the mainstay of treatment from a medical standpoint. Now, again, the medical compression stockings, you remove them daily. You put them on first thing in the morning when you get up before you get going too much because the swelling starts pretty quickly. And you want to prevent that swelling from occurring, so you wear the compression stockings, you wear them all day, and you take them off at night. One thing I found in my practice is that, unfortunately, a lot of these patients you don't realize that are chronic sleep in a recliner. So they sleep in a recliner with their legs dangling the entire night, which, as long as the legs are below the heart, they're still pooling and going on at that point. And if you don't get the legs at the level of the heart, at least level with the heart when you sleep in a bed or above your heart, which most people don't sleep with their legs above their heart, but at least getting back to level, then this process is occurring 24/7 for them. And one thing I advise people not to do is sleep in a recliner because that just causes more problems with the pooling as well. So those patients, some of those patients, I'll tell them to wear their compression all day and all night. Just because the fact is that if you don't have that, it's going to cause problems. Let's see. So therapies we talk about, and these are just names of different things people may have seen, but I don't expect anybody to know them or go through them really. But there are 3 main things that we do surgically. One is the old surgical stripping. That's what people in your generation used to experience because we didn't have these minimally invasive techniques. We would actually go in, we would take and ligate the vessel up here, we'd run a catheter from as low down in the leg as we could go, and we would actually just kind of rip the vein out. And it would tear the vein all the way down, it would bleed. We'd wrap it with an ACE wrap, and you'd be uncomfortable for 4 weeks or so. And that's the old vein stripping. That has about a 75% efficacy, meaning that 75% of the patient will actually have long-term success with that. And so there's the newer procedures we actually have better outcomes than the old procedure do. And they're much less painful and much easier to tolerate, and most of them are now outpatient procedures. The different things we do is, one, we use heat. It's just called thermal. And tumescence is where we inject. The original first things we started with were laser, and I'll kind of show you some pictures of this stuff here in a second. So the laser, these are the heat closures. So laser, basically, when you talk about lasering the veins, a person, they'll run a catheter, run this laser up the leg into the area that they want to treat, and then they'll treat it kind of backstepping, just kind of pulling it all the way down. The problem with the laser, for one, it's painful, so you have to have what's called tumescence. Tumescence is we have to inject a local anesthetic all the way along the entire vessel and put compression around the vessel so that the vessel closes around this catheter, so that when we're using heat to seal it shut, that heat actually goes uniform and goes around it. But that heat can't go elsewhere in the body, because the biggest problems with these 2 procedures is that heat can transmit into areas that can be dangerous. You can potentially damage the nerves, And below the knee, that's the problem we run into, is below the knee we can't treat with this procedure because there's a nerve that gets involved that actually can get damaged, and you end up with chronic pain associated with, or numbness. So we can't use this, we can only use this kind of from the knee up. But going back to the laser is more uncomfortable because for some reason it seems to cause more damage to the surrounding tissue, and patients tend to have more pain from it. So we now have what's called radiofrequency ablation, which is basically, it's just vibrating. You got a catheter that vibrates really fast, it causes heat, and that heat sears the inside of the blood vessel and then damages it, and it seals shut. And that's the purpose of the treatment. We're sealing that vessel shut so that the blood flow can find another alternate route that works normally. And that way you actually are able to alleviate the symptoms and problems. And 80% of the people get symptomatic improvement with any of these type of treatments. So, like I said, the old vein stripping, it's been performed for 100 plus years. It's been around forever. And like I said, this typically requires 4 weeks of recovery, but it is very painful and uncomfortable. So it has to be done under general anesthesia in the operating room. And that we still have to do occasionally, but it's extremely rare nowadays. So we don't have to do that. But what we do is sometimes we'll go after the smaller vessels and treat them with sclerosants, or things that basically scar the little smaller vessels. But in my practice, I like to treat the deeper system first, the primary system first. And a lot of times after treatment, 4 or 5 months down the road, those varicose veins will go away because the pressure's no longer there, and they'll just shrink down. And you don't actually have to do anything with those ancillary vessels. So, kind of going back here. So the other things we do, these are the ones we talk about with foam. So these don't use heat, and they don't use tumescence, but they use foam, basically to seal the vessel shut by chemically damaging the blood vessel. But the problem is they're not good for bigger vessels. They're good for smaller vessels, and they're more for treating varicose veins. So if you've got a varicosity or varicose vein, you can kind of put the sclerosant in it, and it'll kind of shrink it down. That's kind of more of a cosmetic, but it can give you some symptomatic improvement as well. But that's more down the line of once you treat the major problem, then you can come back and treat those other areas. And again, the thing that's the newest, and that's I'm going to talk about a little bit more here too, is this venous seal. And that actually is a process that we have that's been developed where we use basically a super glue. We've taken a super glue, we've learned how to use the super glue material and actually use it for medical purposes. And so kind of going back, that's these different systems. That didn't matter too much. So again, let's start with kind of what these things do. So that one thing that I showed you where you're using the radio frequency and basically the heat to sear the vessel shut. So what you see is this one's not a very good picture, but you can see that after the procedure, the varicose veins are going down and the swelling's going down. This one's not a very good one. But you can kind of see, it's hard to see, but this vessel goes away. But the treatment is basically from the knee up to the thigh. And like I said, this one, it's not as painful as the laser. It doesn't usually require general anesthesia. It's usually a local anesthetic, but it does require that injection, the tumescence, where we're injecting the leg all the way up and down. And that, unfortunately, can be uncomfortable. And so we tend to do this under sedation in the operating room. It can be done in the office, but it's typically done under sedation in the operating room because of having to constantly just kind of injecting your leg all the way up and down. Now we're talking about that new procedure, the venous seal procedure, where we're using the glue. The glue has been used, these are all kinds of different things. We've used it. We use the glue for wound adhesives, skin incisions. We've used it where you have an abnormality in the brain, where you have an aneurysm in the brain that they're now injecting this into, and it's actually clotting that aneurysm off. They're using it to clot if you actually are actively bleeding from a blood vessel somewhere in your body. They can inject this material in it, and it instantly clots. So what it does is it's really surprising. As soon as that glue hits the bloodstream, it immediately clots where it's at. So it doesn't move and migrate. So it's great for treating all kinds of different vessel type procedures and stuff like that. So it's safe. It's been around for a while now. It doesn't cause any pain. Your body doesn't form a reaction to it. So it's very safe overall. The only thing is that typically, if you have an allergy to super glue, you can't have it. I mean, people who have fake eyelashes or fake nails and they get an allergy to the glue, then that's usually meaning that it's related, it's this type of glue that you wouldn't be able to use. So the procedure itself, this is just kind of I'll show you a video here in a minute, but basically what we do is we run the catheter up from as far down the leg as we can go, and that allows us to treat as far down as we can. This is similar to what we do for the laser or for that other ablative procedure, but this one does not require that tumescence. We do not have to inject it. So all we do is we put a little bit of local in the skin, we get access to the vessel, and we run the catheter as far up close to the deep system here, and this is the superficial system, and we basically seal it shut with glue all the way down. And that's an outpatient procedure. You're awake for the whole thing. You only have a little local anesthetic at the level where it's inserted. Sometimes you may have veins that you have to treat in multiple segments, but most of the time you can treat the whole leg at one time. And that allows basically 80% of the people get symptomatic improvement with the achiness, the heaviness, the itching, all that stuff. And it also helps to heal ulcers. If you have ulcers and you can seal the vessel and the connection shut between the ulcers, underneath the ulcers, then they'll heal quicker. So I also do wound care. The wound care patients that we see, if they have this underlying process, we've tried to treat them with that, with the venous procedure, any type of the venous type procedures first, and as well as managing their wounds, but we kind of have to go in and treat some of these other things as well. So again, this is not really important to you guys, but we don't use heat. We don't use the tumescence. We don't use all the injections we talked about. And we don't use a sclerosant because that sclerosant kind of travels. That's the material that can kind of cause the vessel to clot, but that can travel and it can go to different places, and it can go to places you don't want it to. So it's very precise. You have to make sure you're working in a very limited area, because you don't want any of that getting in here, because this goes up towards the heart. So you don't want any clot or anything up in this area up in here. So this is a new procedure. It's been approved by insurances. It's been around now for probably about 6 or 7 years, maybe a little bit longer. But insurances are finally starting to pick up on it because it's much less invasive than any of the others. It's less costly because we do it in the office. It can be done, or an office-based setting. We just have to kind of dot the I's and cross the T's for all the insurance purposes. But this can be done basically while you're awake and with just a local anesthetic. Afterwards, you tend to get a little bit of, you'll feel a little bit of knottiness along the vessel, but over a period of time that gets softer, and hopefully the varicose veins that are attached to that vessel that you're closing will go away with time. And immediate relief. You get immediate relief. The patient's up moving around. They're active. They don't have any restrictions. This can be done on blood thinners. You don't have to stop your blood thinner if you don't need, whereas some of the other procedures you do. So you don't have to do any of that. And it also, people can go back to work pretty much. You can have a little small wound, but for the most part, people can go back to work in full activity immediately. They don't have any real restrictions from it. I personally like to wrap the leg from the foot to the thigh with an ACE wrap, just because some of these collateral blood flows from these varicose veins, if you seal that shut with this, then they can form a clot in them. And if they form a clot, they're uncomfortable. So I try to basically squeeze out the little varicose veins to avoid the bigger, ropier ones, to avoid having clots in them because they're uncomfortable in the short term, and then we discontinue that. So this is the video. This comes from Medtronics. Okay. Yeah. So this is the blood vessel, and the catheter is being run up the blood vessel. You see it coming in here. This is just an animation of it. You see the ultrasounds compressing the blood vessel, and then we just drop glue. And then we put compression on it afterwards so that the glue spreads and seals the vessel shut. And then we drop more glue, and we spread it out this time, and it's a lot quicker. And we just keep, you can do it many different ways. You can do one drop, you can do multiple drops, just as long as you can compress those drops as you go. I tend to do 3 drops and keep on going, but all we do is we compress it, and it seals the vessel shut. That super glue, that cryosinolate or acrylate, actually immediately seals and immediately becomes hardened and firm when it gets in there. The thing is, it is kind of rubbery, so it's not like it's a piece of plastic. It is kind of rubbery, and again, it's just a Band-Aid procedure. So overall, they're showing it at the level of the knee, but we can go down as far as the vessel allows us based on the size. The problem is there's a lot of collaterals and stuff down lower where all that disease is occurring, and you end up having to seal those vessels shut down there. Otherwise, you get the ulcerations and stuff. So the benefits, again, this is local anesthetic only. You're awake for the whole procedure. Like I said, we can treat the entire leg from the ankle to the thigh. You don't have to stop just at the knee if we can get it there. We can also treat multiple different vessels. We try to do that in segments. We don't try to do it all at the same time. But again, almost immediate return to activity. And again, if you're allergic to super glue, fake nails, or eyelashes and have problems with that, then you can't do this procedure. And we'd probably have to go back to the one that actually has the heat. So, kind of a synopsis. Hopefully I didn't go through too much, and hopefully I gave you enough information to make you understand this without being too much medical jargon. That chronic venous disease and chronic venous deficiency is because of the pooling that occurs in the vessels. It's undertreated. Again, a lot of people just ignore it because as they age, they know they're going to have problems, and it doesn't bother them that much that they just don't realize that there are ways to treat it that aren't the old vein stripping. People think the old vein stripping was horrible. Everybody knew that. There's a lot of people that out in the community know that my grandmother had that, and I don't want to ever have anything like that again. So done to me. So most people aren't aware that there's these minimally invasive procedures now that people can do, and 80% of the people get symptomatic improvement. And again, it's not just cosmetic. We're talking about that you have varicose veins. That a lot of people think that that's cosmetic, but the underlying disease process is what we're trying to treat. We start with medical management, but again, that only takes care of the symptoms. It doesn't actually cure the disease. So we tend to treat it first, and insurances require that you attempt a medical management, and people get some improvement and relief from the process. But unfortunately, as long as the disease process is not taken care of, then if you don't take care of the disease, it's going to continue, and it's progressive and worsening. Again, the minimally invasive procedures do exist, and people do really well with the procedure. And again, treatment is not curative. It reduces the initial medical management treatment is not curative. The procedures we perform are curative, but as long as gravity is working against you and you're upright, the body's going to find other ways, and you can have this happen again in other areas. So, any questions?
My daughter is a nurse.
Yes.
And she wears the compression socks kind of as a preventative.
Mm-hmm.
Is that a good thing?
I think so. That's what I do. being on my feet all the time, I wear the compression stockings because I do have a little bit of achiness, heaviness myself. I may have some reflux disease, but when I first started this, I used the ultrasound and checked myself, and I didn't have it, but I was having a little bit of symptoms. So you don't always see it necessarily show up immediately, but yes, I do, because the swelling tear and the pressure tears up the skin, and it's a long-term process. And once you develop it, then you're running the risk that you're going to develop. It's going to be harder to treat. So it is a progressive process. So I do recommend that if you're in a lifestyle where you're standing for long periods of time, then yes, I would recommend wearing them to help prevent things. Yes. No, it does not. So if you have symptoms, the achiness, the heaviness, the itching, burning, all that stuff, and you have reflux, which we have to do the ultrasound to look at, we have to give you a period of medical management. A lot of insurances used to require 3 months of medical management. You had to document that you wore compression stockings, that you elevated your legs, you exercised, you had many, many different visits, and we had to document all that to dot all the I's and cross all the T's. Fortunately, they've come to understand that this is a chronic process. It's not going to go away. We've treated you medically, and you still have your symptoms are better, but your symptoms still persist. So as long as you have persistent symptoms, despite medical management, you don't have to jump through all those hoops anymore. Insurances will cover it. Now, the insurances, Medicare and Medicaid do cover the venous seal procedure, but some of the other insurance companies are still not picked up to the newer glue-based procedure. We've got long-term studies now that are over 5 to 6 years, and that's all we needed the first time to get approval for the other procedures. But for the most part, insurances will cover this, and it doesn't require a whole lot. We examine you, we treat you. Surprisingly, they don't require compliance anymore, meaning I can say, you tried the stockings. Well, you couldn't get them on, therefore you tried. You put the stockings on and they hurt you too much, you had to take them off. So it is best to wear the compression, but if you can't tolerate it, because there's a lot of people, different anatomy, you can't tolerate the stockings, and some people can't put them on because of arthritis. We do have little devices, little donning devices where you put it over kind of this little device and you step into it that help, but some people can't get them on. And the pressures that we put on for treatment are higher than some of just the regular stockings. So the stockings they put on for surgery are really lightweight. Those aren't the compression we're talking about. We're talking about a much higher compression. And those are really hard to get on. I use a mid-weight. That's kind of the one that's over the counter. I use a mid-weight. They're difficult to put on, but they're like a dress sock. They're just something I wear them just because I'm on my feet all the time. But they're more like a dress sock, so they're not these medically sheer. They're more kind of something I can wear, but I personally still don't wear them when I'm in shorts or anything like that. Some people have to because of their medical condition, but overall, long story short, yes, they get covered by insurance most of the time, and it's usually pretty easy to get it approved. Something else I was going to say, but I can't recall right now. Right? Yes, sir.
Is it necessary to wear the compression stockings
With
with the sock in?
a sock in?
The sock. The ones I have on now are just the sleeve that runs from the ankle to the knee.
Right. So, yeah, it depends on the person, but a lot of times, unfortunately, they act as a constricting band around the ankle, and you get swelling in the foot. If you get swelling in the foot, then yes, you probably should wear a sock version. They come with toed socks. They come with ones that they're toeless, but they are on the foot, and then they come like that, where it's more of a sleeve. It's variable as to what works for you. Unfortunately, with a lot of the sleeve ones, what I see is the foot getting swollen. And if the foot gets swollen, you can have damage. You can actually have ulcerations and damage to the foot as well. But if it's not bothering you, then any compression is better than nothing. So, you're welcome. Yes, ma'am.
The
It's 95% of the patients get get a durable closure, meaning long-term that vessel stays closed. So rarely does that have to be repeated itself. That's that main system that runs down the inside of the leg. Sometimes we treat the smaller saphenous, which is on the back of your leg and up on the back of your thigh. Those are the main systems that we treat, but in and of itself, unfortunately, they're collaterals. I mean, that's where we're banking on, is that the collaterals will bring the blood flow back. But if those get damaged long term, then you may have to have those treated as well. But for the most part, the major system does not have to be retreated. But you can have to have additional, do additional work. They said after 5 years, about 75 to 80% of the people still have symptomatic improvement afterwards. But you can go back and treat these little smaller connectors and stuff like that with the sclerotherapy. If you've got a longer segment, you can go back and treat it with the glue, but a lot of it's kind of spot work at that point. And unfortunately, like I said, as long as gravity is working against you, it unfortunately has to be, you may have to have something else done. Now, the one caveat to this is the deep system has valves and stuff too. And if the reflux is in the deep system, unfortunately, there's not a good way to prevent that from occurring, because you can't stop the blood flow in the deep system. That can cause a lot of problems. So if you have the reflux in the deep system, we try to work around the smaller system, the superficial system, and try and treat that to help mitigate the symptoms. But unfortunately, the deep system, you can't do a whole lot with. Or if you've got a blood clot in your leg or limitations like that, then that becomes a problem. Any other questions? So if you know of anybody that has this type of stuff, hopefully I explained it without that you guys can understand it. If you have any questions, you're welcome to contact us. If you know of anybody that has these type of symptoms and want to be evaluated, insurance covers for evaluation. We can bring you in and have you evaluated initially, and we kind of go through the initial workup and start with medical management, and then we will follow that up with ultrasound and management if we feel like it's going to go the direction of having to need a procedure. So.